congenital diaphragmatic hernia, CDH. CDH is a developmental defect of the diaphragm that allows abdominal organs to herniate into the thoracic cavity, leading to impaired lung development and respiratory distress. Definition: a congenital diaphragmatic hernia is a birth defect in which a hole in the diaphragm permits the displacement of abdominal contents into the chest, compromising lung development, pulmonary hypoplasia, and function. Causes. The exact cause is unknown, but CDH is believed to result from a combination of genetic and environmental factors. 1. Genetic mutations. Mutations in genes involved in diaphragm and lung development, e.g., FAUG2, GATA4. 2. Environmental factors, teratogens such as nitrophen exposure in animal models. 3. Syndromic associations, seen in genetic syndromes like Fryns syndrome and chromosomal anomalies like trisomy 13, 18, and 21. Types of CDH. 1. Bachdalic hernia, 90% of cases, posterolateral defect, more common on the left side. 2. Morgagni hernia, rare, anterior or retrosternal defect, often asymptomatic. 3. Central diaphragmatic hernia, rare and located in the central tendon area. 4. Eventration of the diaphragm, thinning rather than a true defect, similar functional implications. Symptoms and signs. Symptoms: respiratory distress immediately or within hours after birth, tachypnea, cyanosis. Scaphoid abdomen due to absence of abdominal organs in the cavity, feeding difficulties in milder cases. Barrel-shaped chest. Mediastinal shift seen on imaging or auscultation. Diminished or absent breath sounds on the affected side. Heart sounds displaced to the contralateral side. Investigations. Prenatal diagnosis. 1. Ultrasound, 18 to 24 weeks. Abdominal organs visualized in the thoracic cavity. Mediastinal shift. Polyhydramnios due to impaired swallowing. 2. Fetal MRI, better delineation of lung volume and herniated organs. Postnatal diagnosis. 1. Chest X-ray, herniated bowel loops or stomach visible in the chest. 2. Echocardiography, evaluate associated cardiac anomalies and pulmonary hypertension. 3. Genetic testing, to identify syndromic associations or chromosomal anomalies. Treatment. Initial stabilization. 1. Airway management, avoid bag mask ventilation, intubate to prevent gastric distension. 2. Oxygenation and ventilation, use gentle ventilation strategies to minimize barotrauma. High-frequency oscillatory ventilation, HFOV, or extracorporeal membrane oxygenation, ECMO, for severe cases. 3. Hemodynamic support, use inotropes to manage hypotension and maintain systemic perfusion. Definitive surgical repair. Timing, after stabilization, typically within 24 to 48 hours post-birth. Procedure, reduction of herniated organs and closure of the diaphragmatic defect with sutures or patches. Recent advances. 1. Fetal endoscopic tracheal occlusion, FETO, involves temporary occlusion of the fetal trachea to promote lung growth in severe cases. 2. Ex utero intrapartum treatment, EXIT, delivers the baby partially while maintaining placental circulation to secure the airway in severe CDH cases. 3. Improved imaging techniques, advanced fetal MRI for better prediction of outcomes using lung-to-head ratio, LHR, and total lung volume, TLV. 4. Pharmacological advances, sildenafil and inhaled nitric oxide, INO, for persistent pulmonary hypertension. 5. Tissue engineering, development of bioengineered diaphragmatic patches to reduce complications. 6. Genetic and molecular research, identifying new genetic mutations and pathways for targeted therapies. Prognosis. Survival rates, 60 to 85% depending on severity and associated anomalies. Long-term complications, chronic lung disease, feeding difficulties, and neurodevelopmental delays in some survivors. Comprehensive care by a multidisciplinary team is crucial for optimal outcomes.